so you can keep them for later. Share screen. Well, that's not going to work. All right, can y'all see can y'all see my slide now? Somewhat big. Anyone? Okay. All right, I just didn't hear anybody. Okay. So pediatric physical therapy. Now, remember, I don't know if this is chapter 6 in your book. My edition is a little old, but the information is exactly the same. Okay. This might even have some extra, I think, than what your book has. So you may want to take some notes too. But like I said, it'll be recorded. I want to let me go. Okay, so here's our objectives. I'll let you read through those on your own. Blah, blah, blah. Okay. So pediatric PT specializes in the treatment of kids with developmental dysfunctions, from genetic causes, developmental dysfunctions from injuries from related to the brain, the spinal cord, any other organ failure or system, or injuries or hereditary things. The treatment is just like in adults. It can occur in the hospital, outpatient clinics, acute care. It can occur in home health, or kids even get a lot of therapy in the school too. They get even if they go to a clinic and get their own outpatient therapy, a lot of times most school districts will have a few PTs and OTs and speech therapists on staff, and they go through and they do different things up there, and they do small sessions of things with kids in the school system, mostly to help them get set up to where they can learn better with their and interact with their other kids more, so they can feel like they're interacting with peers of their own age. But I think that'd be a fun job. So the PT's role in the pediatrics. So in from 0 to 3 years of age, there is a national program called it's called the Early Intervention Program, or EIP. That is it's a law. It's a mandated for infants and toddlers with disabilities. So if you're 0 to 3 and you have a disability, you automatically fall under this program, an early intervention program. Well, you will automatically get, and this will happen through this will all happen through your doctor, but it's law that you have to do this. You get a PT and then probably OTs and speech therapists too, but the PT is kind of like in the driver's seat. The PT serves as a director, care provider in all the clinics and through the whole program, and will kind of be like the gatekeeper. The other disciplines may fall under the PT in this umbrella, but the PT will be the direct care provider over everything, and then they will relay all that information to the physician and to the insurance company, which is usually Medicaid. In the school system, for ages 3 to 21, we're an indirect provider. So if we're working in the school system, then we may do some individual sessions. We may do some individual sessions just like we would do in a normal outpatient clinic. We may go to PE with them, like PE or recess with the rest of the class, and the PT or the PTA may help the PE coach or the PE teachers learn how to adapt the different games or exercises they're doing that day so that kid can participate too. or they show them different things that that kid can do, so they are participating just as much in PE and recess as the other kids. But it's completely dependent on the specific needs of the child. I mean, sometimes they need to be able to learn how to walk from one class to the next and be able to do it fast enough without getting knocked over if their balance is impaired, and be able to walk there fast enough before they get tardy. So some of them are learning how to navigate their wheelchair through a crowded hallway in between classes. So you're working on things like that, real life things that happen in school to all of us. Other pediatric team members, nothing here you wouldn't know about. And whenever PT is going on at the school, we use the teachers, or we are included on as part of the healthcare team when it's in the school too, because they're the people that are going to be there with the kids every day, seeing them more than us, and they're going to know if our interventions are working or not. So if you see here, this is just a single therapy session. So you see one little bitty kid, but there's 5 adults around this one little kid. This is what a lot of sessions look like with little kids. I mean, you've got, I would think that the little kid is sitting in a lap of a lady with scrub. So I would assume that that's the therapist. You've got somebody else with a name tag on, so that might be another therapist. Usually a lot of pediatric treatments are co-treatments between multiple disciplines, multiple therapists at the same time. Then you might have the parents there. Then you might have a caregiver there. So there's a lot of people that are going to be in the session. So sometimes, you know, that works out in your advantage if you're treating kids, because if the parents are there and their caregivers are there, they may be likely to be more comfortable with you or participate. But parents can be very overbearing when it comes to their kids. So if any of you have kids, you can probably understand what I mean. You know, if you're in a therapy, if I'm a therapist and I'm trying to work with your kid, you're going to want to keep butting in and telling me, but they don't like to do this, but they like this better, but they can do this easier than this, or they can do it this way better. Parents are like that. And a lot of times, more times than not, we have to eventually ask parents to step out of the therapy sessions, or just come in for the last 15 minutes of the session. And we have to say that very gently to them, that, you know, we have to say, you know, I think we want to try some things without you being there to make sure, you know, he can be more independent. And so that's a way you can get rid of overbearing parents without actually calling them out. But it will happen, trust me, to kids. Little babies even get therapy. So this is a therapist that's probably doing an assessment on an infant. It looks like she's testing her grasp reflex. Okay. So this is just a list of reflexes that, see, when we're born, we have certain reflexes that are present, and they disappear as we develop later through life and through our toddler years. And then we have other reflexes that occur as later on in our toddler years, and allow us to do things like walking and things like that. So these are just a few of the different reflexes that we have at birth, but they eventually go away. So just to give you a couple of examples, I'll explain a couple of them. Number one, where it says the flexor withdrawal reflex. So if you were to hold a baby under its arms upright, and then put its foot down on something a little sharp, it would automatically flex its hips and its knees and draw its legs up toward its chest. That's called the flexor withdrawal reflex. The sucking reflex, they have to have that in order to eat. They're not going to be able to breastfeed or drink from a bottle if they don't know how to have the sucking reflex. They have the sucking reflex in the womb, because on ultrasounds, a lot of times you can see the baby sucking the thumb in the womb. And the palmar grasp reflex, if you've ever met a newborn baby or noticed newborn babies, if you put your finger in their hand and then they'll grasp around your finger real tight, that's called a palmar grasp. That's an automatic reflex that they have. But that's just something getting ready for voluntary motor control. Y'all can look up the rest of these to see what these look like. You'll learn all of the pediatric reflexes next semester with Dr. K. Okay, so you also have to look at whenever we're looking at kids, we have to look at them by milestones. So milestones happen at certain months, at certain years, at certain ages. So some things happen by 1 month, some things happen by 3 months. You know, usually by 1 year, kids are walking, give or take a couple of months or a couple of weeks. And then, you know, puberty starts sometime around 11, 12, 13, and then all the way up to 18. And then we develop into an adult. So we're always developing up until adulthood. And so there's milestones with each of those stages. This is just a brief chart that I would like you to briefly know. You may see some of these on your test. This is just milestones for the first year of life. And this is some things that happen, and this says month, age, and month. So for 1 year, at 1 month, they should be able to lay in prone and have head control. And then at 3 months, they should be able to push up on their elbows while in prone. And then you should look down at 8 to 9 months, they baby crawl holding a bottle. So, I'm sorry. I thought I heard something. But this is something you may see on your test. So I would get familiar with these. I'm not going to ask you every single one of these reflexes and every single little thing they do, but just be familiar with what happens in each month for the first 12 months of life. Somebody got kicked out of the room. Okay. These are some infant milestones 4 to 5 months. They can roll over on their stomach, reach for toys, react to music in their own name. They can play for a toy for 2 to 3 minutes before they get distracted. They can start eating pureed foods, things like that. All the way to 3 and 4-year-olds. These are things you should know too. They can throw a ball overhead. They can hop on 1 foot. They can learn entire songs. And you know, you don't have to, and don't try to sit here and memorize these lists, every single thing. Just try to, as I give you the age at the top of the PowerPoint, try to think about somebody or a family member or a friend's kid that you know that might be about that age, and think about how they're acting or what they can do. And that'll give you a good idea, and that'll help you learn these things. So what do we do with pediatric therapy? Well, there's a lot of orthopedic interventions that go on with kids. Kids are born with a lot of birth defects, and birth defects can be hereditary. They can be familial, or they can just be from abnormal development in the womb. And that can be due to disease. That can just be to how they're positioned in the womb. It can just be chance. But things happen. So you can see this little girl here is walking with a walker, but she's got braces on her legs. And she's walking with braces on her legs and a walker. So we do a lot of bracing with kids, a lot of mostly with their legs, but sometimes their arms. We're always doing a lot of stretching on them and teaching their family how to do a lot of stretching. Always doing a lot of strengthening. And don't think that you're gonna do strengthening, you're gonna give them a 1 or 2 pound weight and say, okay, we're gonna lift some weights today. Your strengthening has to be creative. All your all your therapy has to be game and fun related. So everything you want them to do has got to be a game to them. It's got to be challenging physically for them, but you've got to, or you can find an interest of theirs or a game they like and turn it into a therapeutic tool. And pediatric therapists are really good at that. It takes years to get good at that, but it's pretty fun to see the things that they come up with. We may give them mobility aids like a walker, or some of them are going to be wheelchair users. Orthotics are the same thing as braces. We work on their balance a lot, trunk balance, standing balance. And if they're not going to be able to learn, if we're not going to be able to teach their body to do things in a proper, natural way, we may teach them compensatory techniques, how to substitution patterns. But we always try to teach them how to do things the right movement first. When you're dealing with neurological kids, there's a lot of positioning, there's a lot of trunk control weakness that goes on. You're sitting, you can see this little boy sitting on a ball, right? He's sitting on the top picture, he's sitting on a ball pulling a TheraBand. So he's sitting on an unstable surface and pulling a TheraBand, so he's really engaging his core. Most kids that need therapy have a lot of core weakness. So we're always doing things on the balls, on BOSU balls, on swings, on foam, pieces of foam, on soft mats, on trampolines. You can see this picture at the bottom. This therapist is more than likely stretching him out. And she's probably putting him in a position to make him use his left arm, because it looks like that he may be somebody that is a hemiplegic, and maybe if his left side is the weak side, she's making him bear weight on his right side, so that if he wants to play with that toy, his left arm is the only thing he's got available. And you can also see she's got her hand over his hand, so she's not letting him use it. So we do little tricks like that too. A lot of family education, because parents are always going to think they're right, but we've got to teach family how to, how to position their kids and how to do these things at home with them, because parents have to buy into therapy too, and they've got to know they've got to do these things at home with their kids and carry over things we do with them every day, or the kids are not going to reach their milestones. Sometimes respiratory therapists have to work with them. So we'll go into a few specific diseases now for pediatrics, pathologies, and you'll learn more about all these pathologies next semester in pathology with Dr. D. Cerebral palsy, usually called CP, is basically you can read this whole slide. It's basically a stroke in the brain, but at birth or before the age of 2. So it's a stroke during or at birth or before 2 years of age. And it's a stroke just like any adult would have. If you're other risk factors for having it, the more premature you are, the more likely you are to have a stroke and have CP. The lower the lower you weigh, you're more likely to have CP. If your mother had poor nutrition, smoked during pregnancy, didn't take care of herself during pregnancy, you're going to be more at risk for having a stroke and having CP. And so there's a lot of risk factors, but if you take care of yourself during pregnancy, and some things can't be helped, obviously, but there are things that, as long as you're taking care of yourself prenatally, those are always the good things you can do to lower your risk factors. So there's different types of CP. You don't have to don't worry about memorizing. Well, just know you can know the different. Don't worry about the different areas of the brain, the different species, the different types of CP occur in, because this is not 100% accurate as to what part of the brain it occurs in. But just know that there's some types there's spastic CP where they're tense and their muscles are always contracted and tight. That's the most common form of CP. Their muscles are always tight and drawn up. We always are having to stretch them out. Athetoid is where they're kind of an uncontrolled movement of their head and their eyes and their limbs all the time, kind of writhing all the time. Rigidity is just when they're really like a stone statue and you can't move them. Tremor is just when they have a lot of shaking. Ataxic is a poor sense of balance and in coordination. But the most common type is spastic CP. But anybody with CP can have any combination of, or all of they can have any of these symptoms, or they can have a combination of any or all of them. Although spastic is the most common type, they are likely going to have some tremors, and they're likely going to have a little bit of ataxia too. And the same thing with the other ones. And so you can see two different ends of the spectrum of CP. You can see this kid on the left side of your screen. He's running. You can look, if you look real close at his legs, he's got short leg braces on, and I can tell that because they're strapped. He's got straps on his ankles, and he's got straps just under his knees, and they're plastic. So there's going to be plastic on the back of his legs and going down around his ankles, and there'll be plastic holding his feet in place in his shoes. But they still have a joint in the ankle to allow him to run and walk. So some CP kids just need some braces, and they're good to go. But then look at this other kid that's on the right-hand side of your screen. He is a very spastic CP kid. He's wheelchair bound. You can see his arms and are drawn up. He can't straighten out his arms, his elbows. His hands are hanging down in deflection. So that's probably, and if his mother, if that's his mother or caregiver next to him, tried to straighten out his wrist, you probably couldn't. And he may or may not be verbal. A lot of CP kids, they may or may not be able to talk. They may have a lot of cognitive issues, but just like this other kid that's running, a lot of CP kids are fine cognitively. They go through regular classes, they graduate college, they get regular jobs. So the spectrum of CP is very, very large. I've treated kids and adults with CP. I've treated kids that were very, 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 very spastic and nonverbal. And then I've treated adults with CP that were college graduates that had full-time jobs, were married, had kids, and just had gait deficits and needed some strengthening and their braces updated. So, but yeah, they have to go through the same things through life. They don't grow out of it, but they have the same life expectancy. Won't worry about that. Down syndrome, we know about this one. Most of us know this is also called trisomy 21. It happens on the 21st chromosome, and we have 23 pairs of chromosomes, or 46 chromosomes. Well, at the 21st chromosome, instead of having 2, Down syndrome kids have an extra chromosome. They have 3 at that 21st marker. So they have extra genetic material than we do. And so also it's a very, 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 the spectrum of how it affects them is very, very broad. You can see these two guys over here. You can see they all have eyes that maybe that are a little shaped a little bit differently. Usually they have a little bit of a larger tongue. And most of the time they do have some cognitive deficits too, but not all of the time. So there are many, there are many syndrome kids that do have to go through special education and go through, graduation certificate programs, and then go through, maybe live in a group home, or they may never live on their own. Or they may get married if they find another person that has Down syndrome or that loves them. I've known people with Down syndrome. I had 2 patients one time that were both Down syndrome patients, and they were married, and they were the sweetest little couple. They were the happiest couple I've ever met in my life. And I was just like, these Down syndrome people, if you've never met one, I'm getting off topic here a little bit. They're always the happiest people. They're always so friendly to everyone. And they're just they make your day. If you're having a bad day and your Down syndrome client comes in, no matter how old they are, they're going to make your day because they're just so happy to see you. And it's every time. But there's many Down syndrome people that are actors and actresses in Hollywood, that don't have any cognitive deficits. Now if you look at them, they'll have the same facial features as a Down syndrome person, and they may have the thick tongue and the little bit of an impaired speech, but they're totally cognitively aware, and they can talk, and they're actors, and they can do full-time jobs and hold down regular jobs and have regular degrees. So just like other deficits, kind of like autism, it's a very wide spectrum. They also have a lot of Down syndrome people also, they also have a lot of trouble when they're kids. They have to go through therapy a lot because they have a lot of trouble closing their mouth. So they will drool a lot. So they'll have to go through trouble. They'll go through therapy closing their mouth, keeping their lips closed, keeping their tongue from falling out of their mouth, because their tongue usually is a little bit bigger. And we have to educate their family regarding their C1 and C2 vertebral stability, because in Down syndrome people, those ligaments around C1 and C2 are very, very weak and lax. And so it's very, very dangerous for Down syndrome kids to do things like gymnastics or tumbling or somersaults, or any kind of sports until they've been cleared by orthopedic physicians. Another is Duchenne muscular dystrophy. It's a degenerative disease of the muscle tissue. It's X-linked and it's inherited by boys. So it's X-linked recessive. So it can't and it runs through and it can only be given by the mother. So boys are the only people that get it. It starts off with atrophy of the leg muscles, usually anywhere around 6, 7, 8, up to 10 years old. You start getting atrophy of the leg muscles. You start getting contractures of your heel cord, of your calf, the Achilles tendon. Your thigh and your hip muscles start getting tight and weak. Your heart you start developing cardiac arrhythmias and cardiac problems, and then you eventually develop intellectual impairments. Those take a long time to develop, and it's a very big stage. It's a long stage they go through, but this is like what a typical kid would look like when they're when they're still ambulatory. They're going to be walking on their toes. Toe walking is little boys that walk on their toes all the time and that are toe walkers. That's a big indicator that they may have muscular dystrophy. So that's always a big concern when that happens. They'll start to develop knee hyperextension And then you can look, they start arching their back too. That's when you really, and they stick their belly out too because they're arching their back so much. That's a typical Duchenne muscular dystrophy walk that they get. Now, they're not going to walk like that for very long. As their muscles degenerate, they're eventually going to become wheelchair bound, and they'll go straight. We're not, because they have a degenerative muscle disease, we don't want to put them in a manual wheelchair because they would have to propel it with their arms. And if they have a muscle disease, well, that's just going to tire them out in no time. So we put them straight in power chairs. And it's kind of funny. This is a little side story I have. When I was in PT school, one of our service projects we had to work for 2 weeks at a summer camp that was for only with kids with physical disabilities. And the 2 weeks that we were there to work was muscular dystrophy camp week or 2 weeks. And so we were the camp counselors, and it was our job to do the transfers and to make sure they wore the orthotics, but we did all the typical camp ropes courses with them. I mean, kids in wheelchairs are being lifted up in trees, and on kids are strapped to their wheelchairs going through ropes courses, and it's hilarious, and you think it's crazy, but they're having the time of their life. But these kids are for the most part normal. They're regular kids. They want to do all the things normal kids do. They turn their wheelchair speed up to super powerful. So, I mean, I can't tell you how many times that I got cornered or somebody ran over my toes with their wheelchair flying by me, and it was a blur. I never even saw who it was because they're going so fast. And they're all like that. They're just regular kids, and they like to go fast. Eventually, when they lose their ability to walk, they'll do a lot of therapy in the swimming pool, because just like the polio kids that back in the early days of therapy, water, the buoyancy of the water helps them and helps them to keep their core strength and to keep all of the strength that they have for as long as their body will let them have. We all know what scoliosis is. It's just a curvature of the spine. It's a lateral curvature of the spine. So we were probably all tested for this in school. So if you have a severe scoliosis, you're gonna be able to see it in your shoulders. You'll have one shoulder and one shoulder blade that's higher than the other, and you may even be able to see it in the hips and the pelvis as well. And it may even cause you difficulty, and it may even look like you walk with a limp when it's really not a limp. It's coming from your spine, and that can be a mild scoliosis can be corrected if it's caught in time without surgery. But if it's a severe scoliosis, they do surgery, and they'll put they may go internally on the back and on the vertebrae, and they may fuse several vertebrae together with rods and screws, and that they'll wear that the rest of their life. Okay. This is a lady that has, I would call this probably a mild scoliosis. We're looking at her from the back. These are people that have body braces that they wear. Now, this is not something that they wear all the time. Don't think that they're wearing this 24/7. This is probably just something they wear at home or when they're exercising, so they can keep their body in the right alignment while they're exercising or while they're doing things at home. But then in public, they would take it off, of course. One of the last pediatric ones we'll talk about is spina bifida. Spina bifida is a neurological defect of the spinal cord, and it's a neural tube defect. So there's different forms of spinal bifida. So if you look at these pictures here, you're looking at a cross section of the body, like if we cut it down the sagittal plane, like in half, and you're seeing the vertebrae and the spinal cord there. Well, if you look at the first little picture, that's called spina bifida occulta. That's the most mildest form of spina bifida. And the only thing that doesn't form is the vertebrae doesn't form completely over the spinal cord to protect it. So if you can look close enough on my picture, or to look at your own PowerPoint slide when you pull it up on your screen later, you can see there's not a vertebral, like a spinous process there, and the lamina is not there. So of the vertebrae, if you learned what the lamina is yet. So it's just kind of open to the skin. So it would be open to getting a lot of injury. Usually they know that by, there will be a big dimple in the skin when the baby is born, and it usually has a big, it's kind of weird, that it will have a big tuft of dark hair growing out of it. That's usually the big goat. That's usually the telltale sign. They have a dimple with hair growing out of it in their lower back. That's spina bifida occulta. It's really, really strange, but that's what gives it away. But they can definitely do surgery to correct that. I know I've known of a couple of people that have had that. They do surgery as a baby to correct it, and then they usually have no deficits at all, and they have a normal life. The next one is called spina bifida meningeocele, and that's where the actual meninges, so the covering of the brain in the spinal cord is called the meninges, okay? It's a 3-layer covering. It's called the meninges. Well, in this case, the meninges have kind of punctured out of the body and poofed out of the skin, almost like a hernia. And now, when the baby is born, they can actually see this big bubble of tissue that's filled with cerebrospinal fluid that's on the back, that's on the baby's back. And a lot of the times the spinal nerves are freely growing into that. So they'll have to go in and put those nerves back into place as best they can, hoping that they don't do any damage, and then fix the meninges. In that case, the kid is going to have to go through a lot of therapy for walking, and they may or may not keep physical deficits for the rest of their life. The last type of spina bifida, and this is the worst case, is called myelomeningocele. This is where the vertebrae have just completely not formed, and the whole spinal cord and the meninges are herniating out of the body. And so in this case, there's going to be a lot of nerve damage that's the baby is that's gonna suffer. So a person with myelomeningocele will 99% of the time will be a wheelchair user for life, starting as a toddler. So you can see that babies with spina bifida, we do gait training with them. You can see this baby on the left. We have to squat down and get on the floor with them, but we do gait training with them just like adults. And you can see he's got this little, I don't know if it's a boy or girl, looks like has long leg braces on. So they're doing gait training. But this other little girl, maybe she had a more severe form. She's got a personalized wheelchair. She's not much older than this other kid, but she's got a personalized wheelchair that's fit just for her. And she looks like she's the happiest little girl in the world. She doesn't look like she's missing anything. Just because little kids are in wheelchairs, that doesn't mean that they think that they're different. If they start off younger in life in a wheelchair, they don't really think they're that much different until they get older. If they start off in a wheelchair, it's almost like their norm until they get to school age and things like that. But these little kids are fine in wheelchairs. Cognitively, these kids are fine. These kids have no cognitive impairments. They're completely there. Very, very smart kids. What do we do with spina bifida? Lots of family education, lots of stretching and positioning education to minimize deformities and contractures, lots of strengthening of what they have. So a lot of playing to make them stronger, a lot of playing in leg braces to make them use their legs and their back muscles, because sometimes their back muscles will be weaker too. A lot of balance and braces. So in summary, Pediatric disorders are usually going to involve orthopedic and neurological disorders at the same time. And sometimes other things come along with that, like heart problems come along with some of these disorders too. So like muscular dystrophy, you know, it's a neuro disease that affects that degenerates the muscles. So it's kind of neuro and orthopedic, and it affects their heart, and it affects them cognitively. So it affects multiple systems. So it's a lot of things can go on when you're dealing with kids. Okay. Well, I didn't mean to do that. Okay, guys. So that was all for peds. Let's take a 10-minute. Let's take a 5-minute break. I'm going to pause the video. Resume record. Am I recording? Yes, share. There we go. Okay, so here's the objectives listed for the PowerPoint. I'll let you read those on your own. Okay, geriatric PT is just the specialization in the treatment of older adults, and most of their problems are musculoskeletal and neuromuscular in nature. There's many musculoskeletal and neuromuscular things that are common with older adults that just happen with degeneration of the body with age. And then there's certain diseases that attack those systems too that are common in older adults. We've already talked about how fast the older population is growing. But you can see that they're not just because you're old doesn't mean you have to slow down. So you can see this man holding the basketball looks pretty fit to me. Looks like he could beat me in a game of basketball. I mean, anybody could beat me in a game of basketball, but that's way beside the point. Looks pretty fit. These other people look a little younger than him, but they're walking on the beach. Nothing looks wrong with them. They're living a good life. So just because you're older doesn't mean you have to slow down and you're going to get sick. So these people I guarantee you, these people are older and still healthy and living a good athletic life because they did that when they were younger, and it's carried over. These people, more than likely, now I'm not going to say all of them, but these people are a little older, but they're a lot less mobile than this guy playing basketball. This guy playing basketball probably is about the same age as these women here in these pictures. And they're doing their exercises and sitting. Now they may have had strokes, they may have other things going on with them, but they're less mobile and less independent. So they're a different type of geriatric population. I love this picture here of this lady smiling because she's got a corsage on, and she might be in a big wheelchair, but she's got her glass of wine there with her, and so she's happy as a fly. So focus of geriatric rehab. We're not there to pump them up, and we're not there to make them build muscle and to, become muscle men. We're there to work on more functional goals of everyday things that they need to do. So if they need to be able to learn how to get up from a low chair again, then we need to work on sit to stands from low surfaces. If they need to learn how to walk on an uneven ground again, maybe their balance is off, which is common with older people, then let's work on the balance a little bit. We have to give them a lot of education about their health. Almost all geriatrics are on many different types of medications from many different doctors, and so it's important for us to know, as PTs and PTAs too, what medications our clients are on, so we can know the side effects, and so if we know if there's going to be interactions with anything. Also, we need to know a general about how the nutrition is and things like that. We can always get information about that from their doctor or from their facility. And we want to restore their highest level of independence possible and then maintain that. So when I say that, let's say a man has had a massive stroke and he's hemiplegic on his left side, and he's come out of a month of rehab and he just does not have any activation on that left leg coming back. It's just not coming back. So we're not going to give up on it yet. We're going to keep doing therapy on that leg for at least a year to see what happens. But it's probably not too far off of a bet to say he's going to be a wheelchair user for life or for a good majority of his day. So we would be helping him in that situation become an independent wheelchair user to be able to get himself. He would only have his right arm and leg to drive if he's a left hemiplegic. So he's got to drive with one side of his body. So we got to teach him how to go straight with just one side, make turns, go backwards, get in and out of elevators, go up and down ramps, go up and down little thresholds or curbs in the community, things like that. So we have to work on things like that too. Or if it's somebody with Parkinson's disease, and Parkinson's disease is a degenerative disease, as I told you the other day in the neuro lecture. People are going to come in with Parkinson's all the time for tune-ups. They're going to come in for therapy like maybe once or twice a year because they'll get better with their home exercise program, and then they'll have another little exacerbation of their Parkinson's, and then they'll need some more therapy. They'll need some more help. So they'll come in for a tune-up. So it may be we work on the same things every time they come back, but we're just trying to make sure that they don't lose any more balance or walking ability. So if we get them back to where they were before they had their exacerbation, then at least we're maintaining what they have. So in that case, we're doing like maintenance type work, but don't think of it as maintenance type work to where you're not doing anything important. It's work to keep that person independent as long as possible, or if you don't do it, then they're going to degenerate and they're probably going to die faster, to be honest. So we have to consider their capacity for safe exercise, the effects of inactivity on the patient versus, this should say effects of inactivity on the patient versus activity. So versus somebody that's sedentary and sits around and doesn't do a lot versus somebody that's active, and the effects of normal aging on a person versus a disease that they may have. We have a big age difference between us. So if you're not used to dealing with a lot of adults of this age in your family or in your friends or just your daily life or in your culture, you may not know how to talk to them around them. So you have to be culturally and ethnically sensitive. If they're from a different culture than you, that you don't know a lot about, then you need to find out about their culture. So you at least can know you need to at least know your boundaries, know what to respect and what lines not to cross. Learn coping skills with older people. Older people have different coping skills than younger people. We need to this is really true for old people. Consider a holistic approach, but that's true with all of our patients. We should never get so focused on just leg strength or just walking or just balance. We need to consider everything. If arm strength is their biggest thing and they're getting OT also, but their arm strength is their biggest deficit, then we're working on arm strength too as PTs and PTAs, because that's what's most important for the patient. And advocate for needed services. So if they're getting us, but then they need, say we think they're getting PT or they're getting PT, but we think they need OT also, or we think they need speech therapy, or we think they might benefit from a support group or a caregiver support group, or sometimes caregivers get burned out or spouses can get burned out taking care of their loved ones sometimes, and they need to go to somebody to talk to. So there's support groups all over town for just caregivers. So people think things like that are usually go through social work, so you can get that type of information through a social worker. We do physical assessments, their sensory and their motor. Speech and OT are going to do more of their mental function. OT and speech will do more on their social function and their emotional function as well. But we've got to be able to be in tune with all that too. So you better find out from your OT and your speech therapist counterparts what they are finding out in those areas, because that's going to affect how you interact with your patient. Because they're going to find out through their avowals things that you would never think to ask, or things that you would never find. Because we're focused on more the gross physical things. They're focused on little bitty fine motor things and high level cognitive things and emotional things, which we're just not trained on. So a physical assessment is going to depend on the pathology, whether it's orthopedic or neuro. Usually going to include a little bit of both. You're always going to want to know a little bit about their full mobility, just about how they get around in bed. Can they get up and down from bed by themselves? Can they roll around in bed from themselves? Can they get up from a chair, from a low seat by themselves? Do they have to have their arms to push up from a chair, or it's impossible to get up? What are their hobbies and interests? Because believe it or not, you can turn that into your therapy session. And you can bring their hobbies and their interests into your therapy and make their therapy interesting part of their routine and day. And then you also learn a new way to be creative. And maybe another day you could pull that out and do it with another patient. Learn about their social life. Are they married? Do they have a spouse? Do they have a partner? Are they engaged? Do they have a boyfriend? Do they have a girlfriend? Do they have kids? Do they have grandkids? Where are they from originally? How long have they lived here in Houston? I mean, don't start asking them everything. Don't do a whole interview on them, because most of that's none of our business, and it's kind of rude to ask that. But after a few sessions, they're going to start warming up to you, and they'll start mentioning those things, and you'll start knowing better how to interact with them when those things happen. And also, so speech and OT also have to learn a little bit about their social history and their social life, so they'll have information on that too. But the more you know about their hobbies and their social life, the more what was I going to say? The more effective your therapy will be. I think I skipped it. Yeah. Okay. Psychological assessment. These are just some of the questionnaires that they may ask. That we typically don't do, but you just need to know. There's something called the mental status questionnaire, the geriatric depression scale. Usually those are given by the psychologists. For the home assessment, we usually have to get ready for them to go home if they're going home. So we have to make sure that if they're going home with equipment, they can get around their house in their equipment. If they're going to go home in a wheelchair, we've got to make sure that their wheelchair can fit through the front door, or they can get up into the front door if they've got a step or steps. So we may have to, and insurance, unfortunately, does not pay for us to go to people's homes anymore to do home assessments like they used to just a few years ago. So we have to rely on the families now. But that's not a big deal, because everybody has a smartphone now, or everybody has a camera phone, even if it's a bad one. get your family members, caregivers, to take pictures of all the house, take pictures of the front door, the entrances that they'll be using. So you know if you need a ramp or not. If you need, take a picture of the hallway, so you know if the wheelchair has a good turning radius to get into the doors. Especially take pictures of the bathroom door, because I'll guarantee you no bathroom door ever built in a house is going to fit the wheelchair. So it's always going to have to be widened. So you'll always have to see that, but you'll have to give that information to the family, depending on how wide their wheelchair is going to be. Obviously, manual chairs can go through a skinnier door, and a power chair needs a bigger door. Just different things like that. Do they need a roll-in shower so they can be put on a shower seat and rolled into the shower, versus a tub where they can just transfer from their wheelchair onto a seat and then throw their legs over the tub and then just sit there and take a bath if they have a lot more strength. So different things like that. So get your family members to take lots of pictures. They can bring you blueprints, but pictures are the best thing. If they can measure this hallway distances, measure doorway distance widths for you, give you all that information, then you can give the PT all that information, and y'all can together with the patient start figuring out what kind of equipment, like ramps, braces, orthotics, wheelchairs, anything else, standing equipment, you name it, they're going to need before they go home. Now, if they're going to an institution like assisted living or a nursing home, that's going to be a much different type of discharge for us, because we're just getting ready for them to go to the next stage of therapy. That means that if they have to go from us to assisted living or a nursing home, that means they're not quite ready to go home on their own yet, or to take care of themselves. So they're going to not as much care as we were giving them, but maybe a little bit less level of care, where they still may get some nursing needs, maybe once or twice a day. Their meals may be cooked for them, but they get therapy while they're there to get them used to going home. Assisted living, usually or a skilled nursing facility, is the goal is to get home in a few weeks. But a lot of times those people end up staying permanently in a nursing home, unfortunately, because they're just too much. They have too many medical complications to handle for their family, and they need nursing care 24/7. So they would stay in a nursing home. Here's environmental assessment stuff I just talked about. You can look at all that. Where it says clutter and unsafe furniture, I mean, you even got to think about the way your living room is set up, and your chairs and your dining rooms, and how things are set up. You know, can you get around tables? If somebody's walking with a walker, can they get around the living room now between the chairs and the coffee table? And the throw rugs that people put down are the biggest causes of falls for geriatric people, because they trip on them on their walker, or when they're walking over them, they trip on the rug on their foot. They don't pick up their feet high like we do, and they just trip on the rug. So we always, number one is getting rid of rugs. Medicare is for older people, 65 and older. And there's different forms of Medicare. I don't know if we're going through it here. No, there's different types of Medicare, which we'll go through later. And then Medicaid is for children 21 and under, or you can have it before your age 65 if you meet certain financial obligations. So there is a certain poverty level you have to meet. It doesn't have to be poverty level to have Medicaid, but you have to have a certain low income threshold to have Medicaid for your medical needs. Other than that, you would have to wait till you're 65 to have Medicare. Geriatric interventions, we always have to think about the psychological aspects of aging and disability. Like I said, the goal is to maintain the highest level of function for the longest amount of time. So we may not be treating them the same way as we're treating are 30-year-old people that go to the gym 3 or 4 times a week and that are pretty fit. Maybe they have the same diagnosis, but if this person's 70 years old and had an ACL reconstruction or a knee replacement, we can't treat them as heavily as we do a 30-year-old with a knee problem. So, you got to play it safe with the effects of aging. And older people are going to have usually multiple diagnoses, which we call comorbidities, which could be things like if their primary reason for you could be because they had a knee replacement and they're learning to get to walk again. But their comorbidities are they have high blood pressure, they may have some heart problems, they may suffer from diabetes. So you have those things could very well in fact impact your treatment. Okay. Let's see, anything here? Nothing really big there. Just things here just make sense. These are just age-related changes that normally happen. We just move a little bit slower. We get fatigued quicker. We're at higher risks of muscle and ligament tears. So we have to be careful with that with our patients. Usually we walk a little bit slower than younger people. We usually take shorter steps, and we don't swing our arms quite as much, unless you're one of those speed demon mall walker people that walk around the malls, walk all the time. Now those people are crazy and they have long steps and they swing their arms like crazy, but usually not. Usually older people are a little bit slower, shorter steps, and they don't pick up their feet quite as high. So that's a reason that they fall a lot. And we're losing sensation for light touch and sensation in our joints to know where our joints are in space. So that's another reason that we fall a lot more as older people. And because of that, our brain starts to automatically use our vision for our balance system a lot more. So if our body can't rely on our sensation for vision as much anymore, it's going to start using our vision for balance a lot more now. Well, then when people start trying to do things in the dark, well, then they'll start falling, and then they'll come to you, they'll say, I always fall when I'm in the dark, or I always fall at night, or when the lights are down low. So you have to teach them to keep the lights bright. You have to teach them about lighting. But then you can do things while keeping their eyes closed and do balance activities and with them in the dark to make them better without using their eyes. So it's kind of cool. They're all going to have vision and hearing deficits of some sorts, mostly. Sensory deficits, mostly touch, taste, and smell. Their heart's just not going to be working. Cardiac output means how much blood is pumped out of the heart with each beat, and that's just not as much as with a younger person. But if they're an athletic older person and they're fit, it'll be good. It'll be like a younger person. They may get out of breath quicker with exercise, and that's normal. And they may have more side effects of medication and nutritional difficulties and stuff. All normal things with aging. Two different types of patients. One patient is sitting here in a hospital gown, and she looks like she's tied down, and she looks like she needs help to lift that little bitty bar. And here's this other lady in her tracksuit and got her weights, and she's ready to hit the gym. So very, very different ends of the spectrum that we've talked about today. But like I also said, a lot of times those older people that are still strong and active and moving a lot and like to exercise and are strong and not doing quite and are usually the pretty good ones in therapy, they're the ones that have remained active and had a pretty good active life. And the ones that come in and just can't do anything, well, for one, they either had a really, really, really bad injury or disease, or they were just really sedentary for their life. And it's just, this is how their body is. So it can happen either way. Here's a couple of different types of gait training. So you can start off it doesn't really matter where you start off, as long as you know what you're doing and where you're guarding. Some people start in the parallel bars. If I started in the parallel bars, I would not be on the outside of the bars as this therapist is. I would be on the inside of the bars, because the parallel bars, they're going to be holding up most of their body weight with their arms. So I'm going to need to be down there controlling their legs and helping with their balance. Then you can walk with a walker. You can stand at the side of the patient, or you can walking behind them. Just some examples. Effects of immobility. So this is just people that are sedentary. They tend to get pressure sores or pressure injuries, like you've heard of bed sores, like people in nursing homes may get. Anybody that's sedentary, if they just sit around in their couch all day and for hours on end and never move around, they can develop pressure injuries of their skin, contractures, or just permanent shortenings of a joint and muscle and a tendon, loss in bone mass, just deconditioning of their heart and their lungs. They tend to develop more of it. Those people tend to develop, they have more, sedentary people tend to have more of a negative self-image than active people do. And that's true for even young people too. The more active people are, the more people exercise, they usually have a better self-image and better mental health and less mental health issues. People that are sedentary tend to be more depressed and more confused a lot of times, and they lose their independence really fast, and so they rely on others to do things for them. So you don't want to go down this road. These are all very much preventable. Fractures, the most common fracture sites in older people are always going to be the spine, the hip, and the wrist. So you probably hear of old people getting hip replacements all the time because they break those hips all the time. That's always loses bone mass there. If they fall and reach out to catch themselves, they're going to break their wrist. That's common. And they can have compression fractures in their spine. And that's what causes a lot of older people. If you see older people, they're stooped down, like really forward and stooping in a forward kyphotic flex posture. That can be caused by compression fractures of their vertebrae over time. It's not a strength thing. It's a bony change that's happened. Here's some information on hip fractures. About half of the people that get hip fractures can't resume their prior level of function. It just, for some reason, zaps a lot of independence out of them, and a lot of people don't resume their level of function. The older they are, it also depends on that too. The younger they are, they'll be more likely to get back to their level of function. Treatments based on the type of the surgical procedure they have. There's different approaches. You'll learn about all of that during semester 3. And that is it. So let me stop sharing. So that's all on geriatrics. So any questions on any of that I went over? Pretty self-explanatory mostly. Okay. All right, guys. So that's all for live lecture. So like I said, I've got one more lecture on the integumentary system that's super duper short. I can probably record it and get through it in 20 minutes. So as soon as we go offline here, I'll get to doing that on my own, and then I'll put it in the video folder page today with this video. Okay. So if you don't have questions, you are free to go.
I have a quick question. On week
Yes.
7, you also have the exam and evaluation orthopedics PowerPoint. Do we go over that too?
My weeks are off on my where'd my calendar go? My weeks are off. Wait, on week 7. No, we
Yeah,
did that
'cause
right. Yeah, so on Wednesday will be orthopedics, and that will be recorded
oh, okay.
because Wednesday is your lab day. So
Mm,
so Wednesdays are always recorded for you because if there's a new lecture, because that's the day y'all have to be in lab, and so you wouldn't be able to. It wouldn't be fair to make you
yeah.
run home for lecture
Yeah.
if you have to be in lab. So
All right. So yeah, orthopedics is gonna be Wednesday then.
Wednesday. Yep.
All right. Just wanted to make sure. All right.
All right.
Thank you.
You're welcome.